Hello, everybody. Hello. Welcome to Pivot Shortcuts. Welcome to the amazing session. If you can see me and if you can hear me clearly, please type a yes in the comment section. Today is going to be another great evening. We're going to focus on some of those key updates that you need to learn. We're going to look at the CNS today. Last time we had a fantastic session, but this was on different areas of the BNF with the updates. Today we will be focusing on just the CNS. Great to have all of you. Nana, how are you doing? Great to have you on. Janice, great to have you. So we may have a mixture of trainee pharmacists, students, and pharmacists as well, because you will all benefit from your updates, from making sure that you have the current guidelines. So CNS, as you all know, is a very, very massive chapter in the BNF. It is one that gets tested so many times in your exam, and it's important that you do everything to learn this. We have quite a lot of updates in the CNS chapter, but we will do our best to cover as many as possible. Will this be recorded, uploaded? This is going to be on here. We're going to be on from 7:30 to 8 p.m. And then from 8 p.m., we obviously have the foundation course. So those of you on the course, you have to join Zoom, where we're going to do our session today, which will be CNS. So what we're going to do tonight, we're going to focus on number one, which is an important recap on all those updates, those key areas that you absolutely need to learn. So we're going to look at those, just focusing on the CNS. So that's obviously for everyone. And then from 8 o'clock, those of you on the course, on the training course, we're then going to go on to Zoom, where we're going to then show you things related to the exam. So that will be more focused towards the GPS exam, areas that get tested, what to focus on, key study areas, practice questions. So from 8 p.m. with all of you on the combo course will be all about the exam. But between now and then, it's all going to be about general updates in this chapter. If you're ready to have some fun tonight, type a 1 in the comment section. Type a 1. If you are ready to go, type a 1. Fantastic. I love updates. And the reason why I love updates is because they change all the time. And most of us are so busy working that you don't really get as much time to stay up to date. So what I try to do is make it very interesting, put it together, and give you the key things that you need to learn. So in this chapter, your CNS, one of the biggest updates is to do with your SSRIs. As we know, these are the most popular groups of antidepressants. So can you guys type some examples in the comments of SSRIs? These are the most important, or the most, I'll say the safest group of antidepressants. And over the past years, we've always had some sort of, we've always had the restrictions about using these drugs in pregnancy. So it's mostly been avoid if you can, and if you do use them, there's always a lot of cautions. What has happened in the last few months is some of these restrictions with SSRIs have been lowered a little bit. So what you're going to notice is we tend to find that in our new updates on SSRIs, they've been distinguished, they've been divided into pregnancy and breastfeeding. So when it comes to pregnancy, previously, it was mostly, if you looked into your BNF, say BNF 83, 82, it's like avoid. Only use it if your benefits outweigh the risk. In the new BNF, or with the updates, that is a bit lighter. So it's still with pregnancy, we need to be cautious. We always need to weigh the benefits to the risk. But another advice is you always start with the lowest dose with your SSRIs when it comes to pregnancy. So can you use SSRIs during pregnancy? Can you give an SSRI to a pregnant lady? The advice is yes, you can. Obviously, once you make sure that the benefits outweigh the risk. And if you're going to do this, or if you're doing any interventions, you're doing your NMSAs or any sort of reviews, just make sure that the prescribers, because all of us are going to be prescribers very soon, make sure you always start with the lowest effective dose. Then another update is when it comes to breastfeeding. So with breastfeeding, it's pretty much fine. But now with the updates, they've had 2 new drugs that have become the preferred drugs when it comes to breastfeeding. So sertraline and paroxetine are those drugs that are, at the moment, the preferred drugs when it comes to breastfeeding. So if you have a patient in the pharmacy that's breastfeeding on antidepressants, SSRIs are safer for that patient. And in addition, between all these SSRIs, your fluoxetines, your citalopram, the most effective for breastfeeding are sertraline and paroxetine, simply because you don't get as much in breast milk. Is this clear? Type of 2, please. Type of 2, if that's clear. Type of 2. So first update is to do with SSRIs in relation to pregnancy and breastfeeding. Okay, this is a big one. And most of you must have realized this. I mean, if you're working in practice, you would have noticed that from the 11th of October, there's this new restrictions in terms of dispensing sodium valproate. So your Epilim packs. The main thing is there's obviously been the pregnancy prevention program. There's a lot of advice that you have to give when it comes to dispensing sodium valproate. But what they did notice is that many pharmacies out there still not giving that information, especially to women. Okay, so what they've done is they want to make sure that this information goes to all women of childbearing age. And the only way we could do that is to make sure we give them the original packs, because on those original purple packs, the packs of sodium valproate, you've got loads of warnings. Like, so you've got all the information on there that women of childbearing age need to have each time this medication is dispensed. So the only way we could do that is make sure that we don't split the pack, so that each time a patient comes in, they have to have an original pack. So with the update from the 1st of October is whenever you dispense sodium valproate, if you're checking the pharmacy, if you're a pharmacist, if you're a trainee, if you're a pharmacy student, whenever you see sodium valproate, if that's meant to be dispensed, if that's going to be dispensed, just make sure it is always in an original pack. Most of the packs come as in 30 tablets. So you could either round up or round down, as long as the amount that you give is always going to be in the original pack. So if you had a prescription for 28, give them 30. Is this clear? So that's very important. Sodium valproate, we always have updates each time when it comes to sodium valproate. Very, very teratogenic drug, one which has a lot of counseling, one where we've had a lot of surveys, we've had a lot of reviews on this medication. So please make sure that you always dispense this medication in the original pack. Great. So we had one with tranexamic acid, not really big. It was just an extra indication. Most of the time we use tranexamic acid in the pharmacy, mainly to reduce the amount of bleeding. So if you have very strong periods, then you tend to be prescribed tranexamic acid. But the new indication, new BNF, has put a new indication, which is for the treatment of hemorrhage following some sort of injuries. Okay, so make sure that you just learn that there's an extra indication that has been added to your BNF. Now, this one is a big one as well. Methylphenidate, we have a lot. We dispense this in the pharmacy. It is a controlled drug. And with controlled drugs, we have to be extra careful. So the only way I could show you this is you have that in the pharmacy. Most of you, if you go into your CD cabinets, you're going to see all those different brands in there. Your Concertas are in there. Your Equasims are in there. Medikinet. It's so important that you know that we are talking about the long-acting preparations, right? The long-acting preparations. So the best way you can understand this long-acting preparations, the reason why we have this is simply because with your long-acting preparations, your XLs, that's a good way to know them, your XLs, if you look at these three different brands, you've got Concerta, you've got Equasim, you've got Medikinet XL. Now, although they're all methylphenidate, if you look in here in terms of how they're composed, the components are a bit different. So you've got an immediate release component and you have a modified release component. These are different for the different brands. So you can see on there, you have 22% of your immediate release in Concerta. But when you look at Equasim, what have you got? You've got 30% in Equasim of immediate release. And then Medikinet XL, you've got 50%. So what does this mean to you as a pharmacist or to you as a trainee or pharmacy student? This simply means, number one, make sure that there's no prescription out there where this is written generically. Okay, so part of your exams as well, you need to know which drugs have to be prescribed by brand. And one of those is methylphenidate. And that's just to reduce the risk of giving a patient the wrong brand. Okay, so first thing you need to do is also make sure that those prescriptions are always prescribed by brand. Then the next thing is the general advice is if a brand is changed, you have to obviously give advice about it. So don't assume that because the patient was on Concerta XL, that's the same advice that you'll give to a patient that is on Medikinet XL. So as pharmacists, the easiest thing and the easiest way to do this is just make sure that before you dispense medication, pull out the leaflet and give the advice based on the leaflet. Because some of these different preparations are affected differently in terms of the interaction with food. So it's important that you just know this. Okay, just know this anytime you see metylphenidate or you see Concerta XL and you're dispensing a prescription, make sure the patient is always being on that same brand. And if they're on a different brand, you have to provide that extra counseling to the patient. Great. So another one we have, another control drug. I've got exam for those of you doing the exam because these are areas that get tested. And in our session later on, I'm very excited about this. In our session tonight, it's all about showing you all those techniques, those tips, those strategies, those questions, those areas that get tested in the exam. So I'm quite excited for the session that we're going to have at 8 p.m. tonight. But in terms of practice, buprenorphine is one of those drugs that has both antagonistic, agonist, and antagonistic properties. So it's a very, very important drug. But in terms of practicalities, it is one of those drugs that also has to be dispensed by brand. Because you have to dispense it by brand because, again, of the risk of giving a different brand to a different patient. So make sure that every prescription you get when you're dispensing that, look at the patient's history and make sure that they are actually on that specific brand of buprenorphine. There are some key things you need to learn about buprenorphine and be very, very careful with these ones. So I know that when I started working as a trainee pharmacist, and I wasn't aware of this, and I actually made this error. I'll put my hands up. I made this error because I'd given out one of these brands that was meant to be. I thought at the time, I did think that all buprenorphine patches were 7 days. So when I labeled this, I labeled it as a 7-day prescription. When I gave advice to the patient, I said the patient put that patch on, and after 7 days, you can change the patch. Until I realized that no, this was actually a 4-day patch. So you need to be extremely careful with buprenorphine. Make sure that you know the difference between a 3-day patch, a 4-day patch, and a 7-day patch. Okay, some are 3 days, some are 4 days, some are 7 days. Now, the way we try to help you out, especially on the course, is I try to give you ways that can help you because you could think about it as so many drugs, aren't they, and so many brands. So how do you know which is which? So an easy formula that I use is when you have a lower strength of buprenorphine, say 5 micrograms. So you take 5 micrograms buprenorphine patches. When you have 5 micrograms, think about everything that's 5 all the way to 20. These tend to be for 7 days. So those patches that you see that 5 micrograms, that 15 micrograms, that 20 micrograms tend to be generally for 7 days. And then those that are a bit higher, those that are from 35 micrograms and above. So if you look at those patches and it's 35 micrograms or 70 micrograms, these tend to be majority of the time 4 days. Okay, so very, very careful with this in terms of your advice if you want to be an effective clinician giving the best advice. So anything that's less than 35, between 5 and 20, or less than 35, normally it's 7 days. Anything that is stronger from 35 micrograms upwards tends to be 4 days. So things like your Butrans and your Butex are normally 7 days. Most of you probably dispense the 7-day patches. Another important information when it comes to patches is you obviously have to give the advice to the patient where to put the patch. Okay, so normally your torso or your upper arm, which is fine. But I guess one of the key things you always have to remember is it has to be clear skin. So no hair on there, no irritation, no condition. It has to be clear, shave off the hair, make sure it's a skin that isn't broken, that isn't infected. And also it's important to tell them when to rotate. So most of them, you could rotate the patch after 3 weeks using the same area 3 weeks later, or some are just a week later. Another absolutely important thing about this drug, which most people don't talk about, most of the time when we dispense this, we don't really talk about this, is the effect that heat has on buprenorphine. So anyone that has this patch has to avoid heat, because what does heat do? Heat is just going to increase the amount of drug that goes into the body. All right, so it increases the concentration of the drug if you go into saunas, if you go into hot places, with buprenorphine. If you're going to steam rooms, having the patch on. So it's so important that you also let patients know. If any of your patients is on any buprenorphine patch, say some Butrans or Butec, then they need to know they need to avoid those hot places if they're going to the jacuzzi or they're going to steam room or they're going to a sauna. Effectively, they need to take this off. Okay, so we're going to cover more. We're going to do more on buprenorphine later on in the class. We're going to do more and show you those questions in terms of converting it into fentanyl, converting between morphine to fentanyl. There's a lot more that we're going to talk about when it comes to buprenorphine. Right, ibuprofen. Why am I focusing on ibuprofen? Because these are one of the common drugs you dispense in the pharmacy. Not only do you dispense them, but you sell them over the counter as well. And in the past, you've always had those restrictions about the caution about avoiding this drug with pregnant women, with breastfeeding women. Right? You will get patients that come into your pharmacy. Some have tried paracetamol, the pregnant, or the breastfeeding, and they want to try something else. And they want to know if they can take ibuprofen because they've tried paracetamol and it's not relieving the pain. So in this case, the MHRA, there's been updates with buprenorphine, so with ibuprofen. And one of those, when you look at breastfeeding with this medication, previously you always try to avoid it. It was always avoid or caution avoid. But the research shows now that it is fine for breastfeeding because you only get little amounts in breast milk with ibuprofen. And we're talking about oral. So this is fine. The one that you need to be very careful about is that's for breastfeeding. Now, if the lady is pregnant, if she's pregnant, that's where you need to be very careful. As a general rule of thumb, I will say just avoid it generally in pregnant ladies. Just avoid it because it talks about that they've done more research, just added more onto the updates. So if you look at the ibuprofen, if you look at the section that talks about pregnancy, there's more data compared to what it was last year or the year before. And there's even an area that talks about 20 weeks. It talks about using this beyond 20 weeks. You shouldn't use it beyond 20 weeks if you're pregnant, because that's literally going to cause problems with your amniotic fluid. It will cause a leak in the amniotic fluid of this fetus or this baby, and you don't want that. Okay, so they've gone into more detail about the potential side effects that you could get with ibuprofen. And the general advice is avoid this medication if you're pregnant unless they absolutely need to take it. And if they absolutely need to take an NSAID or ibuprofen, they shouldn't take it beyond 20 weeks, right? Beyond 20 weeks. So once it gets to week 20 of pregnancy, they shouldn't take it beyond that because that increases the risk of getting these problems with the amniotic fluid. So again, you have CHM advice. This is all new stuff. This is June 2023. So I'm giving you guys the most up-to-date information. Summarizing this is avoid NSAIDs in pregnancy if you can. And this is specifically for NSAIDs, oral NSAIDs, but not all of them. So aspirin is still fine. So when we talk about aspirin for preeclampsia, you will get prescriptions where the lady is pregnant, the lady's on aspirin, that's still okay. That's okay, all right? So we're talking about mainly your ibuprofens and your naproxens, your other NSAIDs. So watch out for what you can have and what you cannot have. But again, you will get prescriptions. Some prescribers may prescribe ibuprofen, but all you have to do as a pharmacist is make sure that all the necessary checks are done. The prescriber is aware of the risk. And if they decide that is the medication they still need to prescribe because they've tried everything else, then you have to make sure it's the lowest dose in the shortest time and keep monitoring that patient for potential side effects. Great. So that's your NSAIDs. Tranexamic acid, I mentioned that following is just a new indication for head injury. It's worth just knowing, but there's nothing much to take away from this because the majority of the time when we tend to see tranexamic acid, it's normally for heavy periods. Are you still with me? Type a 2 in the comments. I know we're going through this a bit fast, but type a 2. Type a 2 is about 70 of us on here, which is fantastic. Please type a 2 if you are getting some information. So these are all updates, current updates, just trying to help you to make sure that you have all the updates. This is just from the CNS. We have loads from the BNF. I could spend a whole day with you going through your BNF. And the interesting thing about updates is the moment I do an update with you, there's going to be a new one tomorrow. So I may spend all my time here talking about tranexamic acid, and then tomorrow everything changes. But let's hope that doesn't happen. But when that happens, I will keep you informed. So these are the changes for those of you that may be dispensing hyoscine patches, so your scopoderm patches in your pharmacy. We normally look at your anticholinergic side effects. So with your hyoscine patches or scopoderm, you have an increased risk of anticholinergic side effects. So things like your constipation, your dry mouth. But the difference with this is that this seems to be even more serious and life-threatening. So most of the time when we talk about anticholinergic side effects, we look at things like your constipation, your dry mouth. We look at those sort of symptoms, but they're not really life-threatening as such. But with hyoscine, they are life-threatening. They are life-threatening because you're looking at hallucinations, you're looking at comas, you're looking at respiratory paralysis. So now, if you're dispensing any of these patches in your pharmacy, or if you see any of these patches in your pharmacy, then it's so important that you check with the patient, you counsel them on these potential side effects. Because the anticholinergic side effects with hyoscine are totally different from your normal anticholinergic side effects that you may get perhaps with your antihistamines. Then the second one, codeine linctus. I don't need to focus on this. I know most of you already know with everything about codeine linctus, high risk of abuse in the pharmacy. So obviously there's been a lot of consultations going on about reclassifying codeine linctus into probably a prescription-only medication as opposed to something that you could buy over the counter simply because of its increased rate of abuse. So definitely that's one that you need to watch out for. Okay, for codeine, similar. I wouldn't spend too much time on full codeine, but full codeine again is another medication that has been withdrawn from UK market. Some of you may still have these on the shelves, but it's important that you know what's actually going on with them and that they've been withdrawn. Great. So another one I want to point out too. We've got about 6 minutes. And this is one that I'm going to focus on from 8 o'clock with all of you, the trainees on the program. Those of you on our training program, I'm going to focus on anti-seizure drugs, what we call anti-epileptics. Apparently, this term has been changed and the BNF has been updated. So they're no longer termed anti-epileptics. They're now anti-seizure drugs. So there's quite a few updates as well with your antipsychotics to do with mania, hypomania. We have some interesting updates coming. Interesting updates. But with lamotrigine, and the reason why I'm really focusing on this, one of the reasons is because we all know, especially those of you in community pharmacy, we've got Pharmacy First. We've got the whole contraception service where we will be prescribing contraceptives. And so this specific area focuses on contraceptives. And it's to do with lamotrigine and contraceptives. And we have other interactions between patients that are epileptic and taking contraception. So you really have to be on top of your game when it comes to this. You really have to know everything to do with patients that are epileptic and taking certain contraceptives. So this is quite an easy interaction. It's a two-way interaction. So lamotrigine is going to reduce the effectiveness of any contraception. And then the contraception, in turn, reduces the concentration of lamotrigine. So what does this mean to you as a prescriber, as a pharmacist, as a pharmacy student? What does this mean to you? And how do you apply this knowledge in practice? All this means is if you're ever dispensing a prescription and that patient is epileptic, and that patient is taking a contraception or contraceptive pill, the first thing is they will need to have some other sort of contraception, additional protection, because this lamotrigine is going to reduce the effectiveness of the contraception. So in practice, you just have to advise them, have an extra means of contraception, for example, a condom. Okay, so use a condom as well, or your partner has to use a condom if you're on this medication. The second thing is, so that's for the contraceptive part. For the anti-epileptic part, which is the drug, because this reduces the concentration of lamotrigine, that will then increase the risk of this patient having a seizure. So the prescriber will have to adjust the dose of the anti-epileptic In most cases, you may have to increase the dose if that patient is taking contraception. Right? So these are very important, and these are very important. This is a very important knowledge that you need to know, because if you don't know this, you could see patients in the pharmacy that may have seizures simply because you've prescribed them a new contraception, or simply because they're taking a new contraception and all of a sudden that patient starts experiencing seizures. Or the worst case scenario is they've got the anti-epileptic drug, you've given them this new contraception, and now they're pregnant. And like, God, what happened? One of the reasons was because this drug was interacting with the contraception which you just prescribed. So very, very important interaction, and that's with many anti-epileptic drugs as well. This table, I'm going to go into detail. This is actually from our combo course. This is from the course, from the training program, and it's to do with antipsychotics. There were a lot of updates with antipsychotics. One of them is this new drug. I think this was last year, right? It's asenapine. So it's one that wasn't there before, asenapine, ASENAPINE. It's a new antipsychotic. It's a second generation antipsychotic. And it's just worth knowing this because some of you may start dispensing a lot of this drug. But asenapine has been added. But we've got clozapine. That's very, very important that you learn a lot about clozapine. But that's all going to be covered later. So I think we're going to round up there. I don't have enough time to continue with this part of it. This was just to do with epilepsy. There's been updates in the guidance with epilepsy. This was probably last year, the year before. So the year before, I'd say, so not as recent, but it's important that you know your different types of seizures, you know the drugs that are used. And the reason why it's also so important is because we have very important drugs in this section, such as carbamazepine, such as sodium valproate. So you need to know the different seizures and what drug to give for which seizure. So I have all of this on here, but I think we're going to end because it's almost 8 o'clock. But with antipsychotics, perhaps next week, I will focus on updates as well. But I will focus on updates from the infections chapter, which, again, a very important area. We will be getting into this whole pharmacy first service where we will have to prescribe antibiotics for certain conditions. So that's going to be next week's session. Next week, I'm going to focus on infections. I'm going to show you guys the updates in this chapter, in your infections chapter, and things that you need to know, and also show you how you could apply this on a day-to-day basis in your pharmacy, in terms of your counseling, in terms of your knowledge, in terms of making the difference in your pharmacy or within your practice. So I hope this was quite helpful. I'm going to have to stop here, let you have an amazing weekend, or not weekend, amazing evening. And all of you on the foundation program, Training Pharmacists, we will be starting our class now. And in the class, I will go through these. So I'm just going to go back a little bit. So from 8 o'clock, I will be going through a focus on the exam. So we're going to look at GP's exam. We're going to look at the topics that generally get tested, things that you have to focus on, your antidepressants, your antipsychotics, your anti-epileptics, your pain drugs. We're going to do all of that in the next hour. Also 7 key areas to absolutely master. And then we're going to try some practice questions and then go through our question bank. So exciting evening, great times, happy days, people. Enjoy. Feel positive. Pharmacy is great. You got a great profession. Well done for those of you that are pharmacists, those of you that are pharmacy students. Exciting times to be a pharmacist, exciting times to get into pharmacy, so much variety, so much potential. I absolutely love it. I love teaching. I love training you. Thank you all for joining in tonight. Really appreciate your time, and I respect all of you, and I cannot wait to see you guys again next week. Jump on next week, 7:30 to 8 p.m. I'm going to tell you the updates, some of those updates in the infections chapter. See you all and have a pleasant evening. Thank you all. Bye.